Welcome, everyone. My name is Marco Priolo. I am a director here on the board of HFMA. I am very excited to kick off this new educational session that we have here for our member base and for those members that have chosen to tune in. I see we're starting to get some participants showing up and may have some others trickling in here. But I wanted to kick off the event by just giving everyone some background on what we're hoping to accomplish today, as well as why we chose to do this event. So this session was actually supposed to be held last spring in the beginning of April. But as many of you all know, or all of you all know, we had a little bit of a change from March on, and we ended up having to cancel the in-person session. And so instead converted this to virtual. And so we have two sessions today, one around a provider and payer partnership, and then an entrepreneur panel this afternoon. And we've called this session Entrepreneurship and Innovation in Healthcare. And it's a little bit different than our sessions have been with our HSCRC workshop and our accounting updates. As well as some of the compliance work that we've done. This is really looking at a different sector of healthcare, the entrepreneurial space and the innovation space. And it brought in a wealth of knowledge from our speakers here today. And I think you guys will be amazed by, you all will be amazed by the information that they're going to share with us. Where we're going to look at how entrepreneurs in the industry are looking to partner with other providers, be it physicians, health systems, and also insurance carriers on a lot of different ways, whether it's product adoption or funding. We have a number of accelerators that are embedded within many of our health systems. And so we're going to talk a little bit about that today. And what these entrepreneurs are doing to help innovate within the industry and the value that they bring to our organizations, and how we as finance professionals can view these organizations as they approach us with opportunities to evaluate whether it makes sense for us to partner with them in various capacities. So I'm really excited. I think this will be a very engaging day today, and hope you all are excited or as excited as I am. And so Cheryl, Khalida, I want to thank you too for helping us with the logistics here, for getting this up and running, as well as Adam Miller and Michael Kayat, who are part of the planning committee with me to get this started. So without further ado, I'd like to get our first session. And so our first session here is going to be from 11:30 to 12:30, and then we have a 2:30 to 3:30 session later that'll allow people to grab lunch and catch up on emails. Everyone is muted. We're in presentation mode here, and so you're not going to be able to unmute right now or see yourself on video. But we will have a Q&A at the end. And I encourage everyone, if you do have questions as the presenters speak, feel free to put them in the chat bar. They'll be answering periodically, and at the very least, we'll use those to do Q&A here at the end. So, so let's get started. So the first session we have is a really interesting partnership that's been evolving over the last I guess year or two between LifeBridge and CareFirst. This is the payer and provider partnership, and they're going to talk about how they're accelerating healthcare innovation through this unique partnership. And we brought in speakers from both organizations. The first is Mike Batista. He is the director of commercialization for Healthworx, and he's got quite an interesting background. He's been a CEO of a startup, a successful startup here, as well as now he is working for CareFirst in their innovation and investment arm, where they're looking to leverage health technology and entrepreneurship to build scalable and sustainable businesses. He's a graduate of MIT and also received his master's from Johns Hopkins University here in Baltimore. So really excited to have Mike to talk about his perspective on both being an entrepreneur and now working on the insurance side, how they're looking to partner with entrepreneurs. And then from LifeBridge, we have Pothik Chatterjee, and he too has quite an interesting background. He's been quite a bit of awards, top 40, under 40 here in the Baltimore Business Journal. He is the executive director currently for LifeBridge in their innovation and research development arm. And that program department has been recognized by both Becker's and other organizations for their innovation that's been developed. Prior to that, he was co-founder of Brigham Innovation Hub at the Partners Healthcare System, and is a graduate. He has his MBA from Harvard Business School, a master's from Johns Hopkins, as well as his undergrad was from Georgetown. So a couple of smart individuals here with a lot of different perspectives. And so, excited to hear what you all have to say about this partnership. And like I said, for those who are listening in, if you want to type anything in the chat bar, happy to respond to those as we go along. So turn it over to you two. Thank you.
Thanks, Marco. Good morning, everybody. Mike Batista, as Marco introduced, director on our Healthworx team at CareFirst. First off, thank you to Marco and the group for inviting us to speak today. This has been an important pillar of our growing initiative to better engage the ecosystem within both Baltimore and the broader community at CareFirst. And so excited to share some of what we've been doing in partnership with LifeBridge. The way we organize this presentation today, and I know we're going to do Q&A at the end, but start shooting them off into the chat as we go through, is that I'll speak a little bit up front about Healthworx specifically and share some of the things that we're doing broadly that touch on the themes of this conversation: entrepreneurship, developing and fostering the early stage ecosystem, and how we think about just innovation in general at a large payer like CareFirst. We'll transition then into the specific partnership that we have with LifeBridge, the 1501 Health Program, and then Pothik will share from LifeBridge's side some of the other unique programs that they have going on, a number of them in particular related to responsiveness to the recent crisis, so very topical for our current situation. So with that, let me go ahead and get into the first portion of those three agenda items. So again, starting with a little bit of background on what is Healthworx, and sort of assuming a little bit that everybody knows who CareFirst is, but for context, in case not, CareFirst Blue Cross Blue Shield is obviously the Baltimore, Maryland, and Maryland, DC, and Northern Virginia Blue Cross Blue Shield plan. We're the largest plan in the Mid-Atlantic region in terms of Blues plans. And Healthworx within CareFirst is a division that focuses on innovation opportunities. We do like to say that innovation lives across our organization. All of our divisions have and are designed to apply progressive solutioning to the problems that they may face. But we try to help with that coordination. And we, Healthworx, often serve as an arm out to the broader market to bring things in that may be accretive to those innovation strategies or problem-solving objectives. There are three main pillars to the Healthworx team. In Marco's intro, as he mentioned, I direct specifically our commercialization function. But we have three pillars, or three different muscles that we would describe, by which we apply various strategies. So I'll go through them and give a little bit of context for each. So on the first, we have our corporate venture capital team. And this actually probably ties very closely to the topic of conversation here. How does a payer or a large healthcare institution find opportunities to intersect with companies that may not yet be at a level of maturity that we can be directly engaged with them strategically or have a vendor relationship. Our corporate venture arm is one response to that need. And so our venture team, we have a $100 million investment fund targeted towards late seed, earlier sort of Series A companies, organizations that have developed some level of rigor and rationale around their problem space and solution that they're bringing to market. And of course, have some strategic alignment with the needs and the interests that we're trying to solve for at CareFirst. A couple examples of some of the businesses that we've invested in. I'm going to go deeper on one of these as an example in a moment. But Zapari is an example of a company redefining the user experience on the front end of members' interactions with organizations like CareFirst, like a payer. And so in our recognition that just the way in which our members think about and see CareFirst and want to access our products and programs, Zapari is helping us redefine that front door, that digital front door to the experience. And so we're well aligned, which led to the investment there. And then the other one called out here is Socially Determined. Again, I'll speak more about them in a moment, specific programs that we're running, but they are a data science company really focused on social determinants of health. Obviously a hot topic over the last couple of years, in an area where we recognized within CareFirst a gap in our own knowledge and our ability to access new data sources that would help us use that new insight to solve important problems. And so a relationship, ultimately an investment in Socially Determined, was again strategically aligned with that objective. So that's a little bit of corporate venture. Corporate development, a little more traditional in nature, probably exactly what you would define it as, which is the team that helps us organize, structure, and ultimately execute both acquisitions and strategic partnerships with a little bit more of a focus on mature businesses. You may know that CareFirst entered the Medicare Advantage markets recently through 2 big acquisitions, and our corporate development team is the group who brokered those big moves, those big transitions. I'll move on just because I think corporate development for us does focus on the more mature partner space, a little bit less on the earlier stage companies, which I know is sort of the focus for this conversation. And so then I'll go to the last pillar of Healthworx, commercialization, the piece that I get to sink my teeth into every single day. That's the space where we recognize that often when CareFirst does pursue the solutioning of problems itself, we have a very insular view of the world where we only think about that problem in the space that we have it. But in reality, many of our problems are problems felt across the healthcare industry. And as an opportunity to both expand our reach, our footprint, and our ability to bring solutions to market, that's effectively what our focus for commercialization is. And so you would almost see this as the entrepreneurship arm of the Healthworx team, where we're building new businesses. We create companies that look not dissimilar to what our corporate venture team is investing in, but obviously with the rigor, the resources, and the clarity of challenge that we're trying to solve for that CareFirst brings and allows us to achieve by being part of a much larger organization. That said, and I'll highlight it in terms of how we think about working with groups outside of our organization, our commercialization function is a space where relationships and alignment with the entrepreneurial ecosystem, whether it's in Baltimore or elsewhere, is a growing part of our strategy, knowing that folks with entrepreneurial backgrounds, founders, do look at problems and solve challenges in ways that we may not as a large organization think about today. And so finding those earlier innovators who are also solving similar challenges and potentially working with them to co-create or co-commercialize something is an area that we're continuing to explore with some of our early projects in that space. So again, corporate venture, corporate development, commercialization, really the focus on what Healthworx focuses on day to day. I do want to highlight 2 specific programs that talk a little bit more about how we are thinking about a couple of these projects and how they intersect the sort of more entrepreneurial ecosystem. So to take Socially Determined, one of our portfolio companies, they were a partner early on in recognizing that, as I mentioned, we have a gap when it comes to certain types of data and the maturity with how we might apply that data to solving important challenges. And so as an example of how an investment became a partnership, we went from but starting as an investor to identifying diabetes as an area that we wanted to really tackle and go deep with. So you can see sort of the 3 pillars of the program that we're working with them on right now, where alongside that partner, that investment, we're now establishing a definition of how we think about and segment data related to our membership alongside new data that we don't have access to today. It's from the left-hand side there. The second is then applying some of the tools that Socially Determined has to getting more precise and more intelligent on where within our larger membership, our larger footprint, do we need to focus and pay more attention to as it pertains to solving SDOH affected challenges. And then in the third column, and we're still doing this today, so we're sort of right now at the end of the middle activity that you see on the slide, it's going beyond the identification to now solving for some of those specific challenges with interventions. So again, in partnership with Socially Determined, being able to articulate interventions that then can be applied to solve the challenges that have been identified in the 6 communities that we are now focusing on as a result of the upfront analysis of, again, both our data and the data coming in from our partner. So taken as a whole, our sort of initiative here is to get smarter, get precise, and actually bring some new solutions into our membership's ecosystem, educated by a greater understanding of what their pain points are, and pain points that don't always sit within the sphere that we typically think of ourselves in the health specific related factors. The other project that I'm going to highlight briefly is coming from my team, our commercialization team. It's an area that represents, I think, a good example of when we think about projects or potential startups, or what we call internal startups that we're beginning to develop, they need to have a focus on things that lead to not only significant expansion potential, scalability is important, but significant impact. And again, I think this highlights it well. So Lantern, sort of our project name, is a project focused on supporting working caregivers. So for a little bit of context, and many of you may already know, caregivers represent a significant portion of the population, and we can define caregiver here as an individual providing support to a loved one, family, or friend, and often that support is uncompensated. Often that support is an adult child providing support to their parent or a loved one who may not have someone else or another resource they can lean into. The challenge, if we start to think about where those caregivers lie today, is that caregiving is a hard, mentally challenging, physically taxing activity that often impacts working individuals, people who are employed in a job who now have a job as well as their caregiving responsibilities alongside them. In particular, this last year with the pandemic, we've seen a heightened awareness of the realities of caregiving as individuals who are now working at home have their caregiving responsibilities alongside them. And so we said, for our community, is there a way that we can better support caregivers? A stakeholder that CareFirst wouldn't necessarily think of as within our purview, but a stakeholder that we're identifying and trying to think in new ways that's important for us to be connecting with and to solve problems for, if we do want the collective health and wellness of our community to be improved. And so the sort of bottom line for this project is that we are developing now a solution to support working caregivers. And the quick pitch, again, think of it like our own internal startup, is this is a technology and service platform that connects caregivers with care coaches or caregiving coaches who can help them both empathize with the challenges they're facing and help them achieve milestones that allow them to recognize that they can make meaningful progress in their journey as a caregiver, and recognize that that journey will look different depending on where you are in time. It's a roller coaster of an experience. And so that holistic support that can provide not just health directive support, but things like helping you figure out where your finances are, or how you might support the financial needs of your loved one or the legal needs of your loved one, things that go outside the health sphere, are important ways in which our platform that we're actively developing right now will ultimately be supporting those working caregivers. And we're currently angling towards sort of a Q1 soft launch with some alpha clients around this new offering. So again, 2 projects that I think highlight the kind of work that we're focused on in Healthworx, and hopefully represent to you all our interest in thinking beyond the traditional sphere of health insurance to impacting our membership, our community in other ways. I'm going to transition now to the sort of middle part of our presentation, where we wanted to share more about how we came to this relationship and this opportunity to collaborate with LifeBridge. I won't go through all the bullet points here, they're a good eye chart, but effectively, both of our organizations, I think, recognize the need to not only think beyond our spheres, as I mentioned, but to recognize that we need to be working with others in our community if we're going to make meaningful progress to solving important challenges. It's not on the slide here, but I know a lot of our conversations that led to this recognize that there are new factors, new influencers in the healthcare ecosystem. I know you can find many articles today, for example, about the consumerization of healthcare, the interest that companies like Amazon and others have in this space. And so to be both more proactive and recognizing that if we're not solving big problems ourselves, others are going to start doing it for us, and recognizing that there are novel perspectives that we can achieve when bringing both the payer and the provider mindset to the table. That led to this collaboration over the course of the last couple of years that we've been excited to talk about and to share with you all today. There's a couple different tenets to the relationship, but the specific program that we're launching that we're really excited to share more about is the 1501 Health Incubator Program. And so this is our first step for CareFirst, though I think Pothik is going to talk more about how LifeBridge has actually done quite a bit more of this, which is why they've been a great partner for CareFirst. But at least for CareFirst, our first step into really trying to serve and engage the earliest stages of the entrepreneurial ecosystem. I mentioned our corporate investment team, or corporate venture team rather. They're looking a little bit more upstream. They're not necessarily tapping into the earliest stage, the creative minds that are still figuring out what the right solution is, maybe are still trying to figure out how to de-risk it, but are certainly bringing insights to the table that we benefit from supporting and benefit from understanding and interpreting back into our organization. And so to give a little bit of the history, we were planning, similar to Marco, how he mentioned this event was unfortunately delayed due to the circumstances we're all facing. We had originally intended this program to launch earlier this year, and we do actually have a renovated, amazing physical space for the 1501 Health Program participants to live in. We're excited for them to eventually get back to that when appropriate, but the tenets of the program, the value propositions that we're trying to provide to our participants are still similar. So to highlight them, and then I'll pause after going through this, and Pothik, happy to transition and let you jump in on your view on this as well. But the 3 C's of the program that ultimately represent the hallmarks of what startups would have access to in participating with this incubator initiative are first and foremost capital, recognizing that one of the best ways to inject agility into these companies to help them with the financing side and to help us align with help them access resources they may not be able to access without some additional infusion to get to the next inflection point, their next stage. We also have the capacity as investors ourselves, LifeBridge similarly, to help support that next stage in their funding round. And I myself, through my previous business, went through an incubator program. And that was one of the best features of that program for us. It was helping us really curate the pitch, so to speak, but also develop relationships with organizations, individuals who helped us better understand and ultimately became investors at that next stage of growth. The second pillar is the community. So inherently, the cohorts will have the ability to engage with each other, their peers, but also the opportunity to engage the broader ecosystem that we would pull together, whether that's advisors, mentors, individuals, potentially from this group, who have subject matter expertise and are excited and interested in helping support the progression and growth of the companies that are participating in our program. And then the final one is customers. The ability to, and by customers, I guess you can see the first bullet points here, we mean the ability to help these companies get to the point where they can start more meaningfully engaging and going to sales interactions with their customers. So to get there, that means things like being able to better test and refine and de-risk the product, being able to have access to research and data that helps validate and refine the business model and the proposition that you might put in front of those customers. And then ultimately having some access to support on resource development so that when you do go and have your first or second or 20th pitch conversation, you're able to progressively develop a more meaningful interaction with that potential customer to ideally close sales, of course. So I know I've been talking for a while. Let me pause there for a moment and give it to Pothik to comment on the program that we're launching here.
Thank you, Mike. That was an excellent introduction from the CareFirst side. And thank you to the HFMA for organizing this session today. My name is Pothik Chatterjee. I'm the Executive Director of Innovation and Research at LifeBridge Health. And 1501 Health is really a dream of mine that I'm really happy that we're able to bring to fruition. As Marco mentioned, I came to Baltimore from Boston about 2 years ago, back in 2018. And when I was at the Brigham, which is part of the Harvard Medical School and Partners Healthcare System, we were helping a lot of early stage startups get traction with clinical leadership across our departments. However, one piece that I found lacking was this element of a provider system partnering with a major regional payer to help these early stage entrepreneurs understand this vital question about how they can get paid for this technology or software platform that they are building. Because if they can't figure out the reimbursement, even if clinicians and patients have a desire to use their product or service, they're not going to have a sustainable pathway forward. So when CareFirst and Healthworx approached LifeBridge approximately 2 years ago, and when we found all these commonalities in our innovation strategy, it was a really great fit. And it's taken us 2 years approximately to really build this program. And with COVID, we obviously have had to pivot and launch. We're launching with a virtual strategy for Q1 of 2021. But as soon as it's safe enough, we hope that we can use the space for co-working for these startups as well. And one concrete way that our partnership really took flight last year was with our Shark Tank Challenge, where we opened up applications for startups all over the country to apply for a prize of $50,000 to the winning startup. And the winner was socially determined. Out of those 100+ startups that applied, and we had a panel of judges that included the CareFirst CEO, Brian Pinnick, as well as our president from Sinai Hospital and our CIO, our Chief Informatics Officer. So that was a really great first step that we took. And now we are doing a pilot with Socially Determined with our Population Health Management Department to use their heat maps and social determinants data to help our care managers triage patients and understand the holistic picture and challenges that patients deal with. So with regards to 1501 Health, I do think that the payer-provider partnership is really unique in terms of accelerators across the country. And I believe that the combination of clinical validation and pilots that we can help organize through LifeBridge Innovation and the reimbursement mentorship and feedback will really help our startups accelerate. And this investment piece upfront will help provide alignment and support as well. In terms of my background, I came from the financial services industry into hospitals about 6 years ago. So I started my career in healthcare investment banking and then moved into venture capital investing in Toronto, Canada with TD Capital, where we were managing $3.5 billion of assets. And so I'm able to bring that VC experience. Mike is able to bring the entrepreneurial perspective. And we've built a really great team between CareFirst, Healthworx, and LifeBridge, combining that financial, entrepreneurial, and operating know-how that I think will help our program really succeed. So I'm excited. We will be launching our website in early January with the application for startups. And one of the benefits of this virtual aspect, ironically, is that we can broaden our net to startups beyond our physical region as well. So we're open to startups from the United States, from the East Coast, and we really want to make sure that we're selective in picking the companies that really align with what we have been calling the Venn diagram overlap of the payer and provider interests. As you may imagine, a lot of that overlap is around cost reduction, improving outcomes, improving experience for our patients and for members on both CareFirst and LifeBridge side. And based on our Shark Tank experience, we do believe that there is a deep well of startups that fall into that overlap that we can mutually invest in and support over the course of 1501 Health and the life of the program. Next slide, please. So moving forward, and we're happy to take questions during the Q&A section about 1501 Health, I did want to share a couple of examples from the hospital side from LifeBridge Health about how we have been dealing with COVID and responding to the pandemic through a couple of areas, including a PPE factory that we developed and remote patient monitoring services. And the third example I'll share is our mobile clinic initiative to make sure that we're providing COVID testing and health screening assessments for our vulnerable populations in West Baltimore. So the first example is this PPE factory. So now we're going back to March and April of this year, really when the pandemic first hit Baltimore and our LifeBridge health system. And it really changed everything for our innovation department as well. Typically I would say before COVID, our department was very focused on being the front door for technology startups that are looking to test, implement, and validate their mobile applications or artificial intelligence software that can help triage patients for clinicians in emergency departments or for surgical triage as well for neurosurgery. That was typically what we focused on before the pandemic. When March came about, everything changed and we completely had to pivot and make sure that we're supporting everything COVID related for our health system. And for those who may not know, LifeBridge Health is 5 hospitals over the greater Baltimore area. We have 13,000 employees and close to 3,000 physicians. We represent the full spectrum of healthcare, from inpatient services to ambulatory network, and we have a post-acute care network as well, and we have an urgent care partnership. So one of the benefits of our innovation function is that we can implement technology and new innovations at the appropriate place within the spectrum and help bring it to scale if the initial pilot meets some of our KPIs around patient outcomes or reduction of cost or improvements in outcomes and quality. However, back in March, as I said, everything changed and the focus really became on COVID. And we found ourselves in a pretty extraordinary situation where we did not have access due to supply chain disruptions to PPE that we needed to protect our 13,000 staff across the system. Specifically, we were talking about masks and gowns, as well as face shields that were needed. And one of the things that I think really differentiates LifeBridge Health is our willingness to act quickly and partner with non-traditional institutions. And that was really brought to light with this COVID pandemic crisis. Given the situation, we were really trying to brainstorm, how do we protect our employees during this time? And our CEO, Neil Meltzer, was able to connect us with Under Armour, who's headquartered here in Baltimore. And we were able to connect with the textile manufacturing and innovation leads at Under Armour. And for Under Armour, this was a new area as well, because as you may know, their main focus is on athletics and textiles for consumers. They had not really entered or looked at the healthcare space before. So it was really a meeting of the minds between our PPE task force at LifeBridge and the textile and innovation leads at Under Armour. And in a very fast, rapid turnaround, Under Armour really came through for us. They were able to come up with a design for face masks and supply the textiles where we could quickly fold the masks using an origami style design, and our staff did not need to have any sewing experience. So within 1 or 2 minutes, these masks could be folded and then distributed to our staff. On the isolation gowns, they did require some basic sewing experience. So from the innovation side, we had this extraordinary challenge at the end of March where we were asked to create a factory in unused hospital grounds. And I have never built a factory before. So this was a real innovation and challenge. So we were given this space. We ordered 100 sewing machines. We were given staff, about 60 staff members who we had to train. We had to come up with an entire supply chain distribution process. We had to set up an assembly line manufacturing process as well with QA. And keep in mind that we also had to implement extreme safety precautions to make sure that nobody in our factory was getting COVID and we were not having infection spread in our factory. So we had to take a very almost surgical approach to making sure that everyone followed safety protocols. Everyone themselves in the factory were wearing masks and appropriate protection, and were getting screened for their temperature every day and symptoms when they came in. And the hardest part of this was the fact that we had to set this up in approximately a week. And within 5 days, we were able to set up this factory. We were able to train everyone. We were able to get the supplies from Under Armour, figure out a distribution system for our 5 hospitals and our ambulatory partners as well. And I'm really proud to say that we were able to do it. We needed 10,000 masks a day to operate safely. And within 5 days, we were able to, within 5 days, we were able to launch the factory. I think within first 10 days, we were able to get to that 10,000 number. And after that, we had to add isolation gowns. So that was another challenge. In parallel, and in the first month, as you can see here, our factory was able to manufacture 200,000 protective masks for employees and 25,000 gowns for our frontline providers who are seeing COVID patients. in parallel, we are very fortunate that we got donations from local schools of 3D printers. So we were able to use a room in our bioincubator program at Sinai Hospital, and we set up a 3D printer farm with those 24 printers, and that was running in parallel, and those created about 4,000 face shields. So we're really grateful to our local community schools here in Baltimore who really came through for us in this difficult moment. Fortunately, after the first 2 months, the supply chain disruption was reduced and we were able to get back to our traditional vendors and suppliers. So we did not need to rely on this factory for a much longer period than that. But it was truly an exercise in rapid ideation. I had to go back to some of my classes from Harvard Business School around Toyota's model for production and how to make sure that you set up the assembly line appropriately. And if there's any delays or any quality issues, you can fix it. So it was really, even though it was very challenging, it was also a very inspirational moment for our team, where we felt like it was almost like a wartime effort and everyone contributed. It was a major team experience. Innovation cannot take credit for this. It was a combined effort between innovation, supply chain management, our PPE task force, our infection control group, who helped us understand how to take a safe approach. And if you recall, back in end of March, Governor Hogan had not made the statewide issue yet that people have to wear masks when they are indoors. So we were a couple of steps ahead, a couple of weeks ahead with our initiative. And I think we made the right decision. And it's something that I'm really proud about this effort. Next slide, please. So in addition to our physical PPE factory that we set up, we were also using technology to make sure that we can provide remote patient monitoring for our patients due to COVID challenges. So our focus was on patients who had come in for COVID testing through the drive-through stations. And as you may recall, back in the spring, there was we were seeing 5 to 7 days delay from the time that patients got tested to when they're getting their results, because LabCorp and a lot of the national suppliers were backed up. So this caused a lot of anxiety and a need for information from patients who had gotten tested and maybe they have symptoms that are worsening. So they really needed to get in touch with a doctor or a PA or a nurse to understand, what should I do? How should I be quarantining? We were getting messages from the CDC, but there was confusion and updates coming in almost on a daily basis. So we were able to partner with a technology company called the Get Well Network, which is also based out of Maryland and Bethesda. And we had been working with them for approximately 3 years. And again, this was the fastest time from ideation about the content and what we need for this product, which is called Loop. I think we were able to get it up and running within 2 weeks, which is significantly faster than any of our past Loop creations. So Loop is a mobile application that patients can get enrolled on after they get tested for COVID, and you get an email or text link, and then you can communicate with your care team through the Get Well Loop application. The Get Well Loop will send automated check-in reminders for patients to see how they're doing. How are your symptoms? Do you have fever? Do you have breathing issues, GI symptoms? And it prompts you to record your temperature, and it provides information about how to quarantine, social distance, and wear masks, and provides links to the CDC website and other online resources. Initially, this platform was managed by our innovation and research department, and we also got help from residents who volunteered to help us with the responses to the alerts and the messages. And then eventually we were able to transition this to nurses, NPs, and PAs from our virtual hospital, which is located at Sinai Hospital. And so we're very grateful. They were also managing with an explosion in telemedicine at the same time, and they're continuing to do that. We have seen, as many health systems, a huge growth in televisits. And we're very fortunate to have the virtual hospital infrastructure already in place before the pandemic. Otherwise, we would not have been able to respond to the remote patient monitoring needs. Another benefit of the regulatory changes in this year was that we are now getting reimbursed from the government for this online activity that helps us sustain this activity as well. Before COVID, we were not getting reimbursed for responding to these online check-ins and alerts. So that was something that helped as well from the regulatory side. Next slide, please. What we found in terms of the data from Get Well Loop and our remote patient monitoring is pretty logically, we found that patients who are getting tested for COVID-19 were much more inclined to use this RPM platform compared to the general public. We have been able to activate over 4,000 patients since the start of the pandemic on this loop. And we saw a much higher activation rate, 56%, compared to our other loops for inpatient and emergency department, which tend to see around a 30% activation rate. You can see the high number of logins, close to 30,000 logins, 2,400 alerts, 4,000 comments and questions. The majority of the alerts were around breathing issues, followed by fever, as you would expect with the COVID patient population. Next slide. Remote patient monitoring really helped us, LifeBridge, support our community through the pandemic, given the challenges of being able to see patients physically. As I mentioned earlier, we found that at-risk populations, defined as patients who tested positive or triggered a red alert, saw a much higher engagement, 80% with the remote patient monitoring. It also allows us to concentrate our clinical resources within the virtual hospital to the patients who are at most need, which is something that really helps us be sustainable throughout the pandemic as well. We found, interestingly, as we know, that we already have social inequalities and racial disparities within healthcare that have been further exacerbated and brought to light by the COVID pandemic, particularly African American population and Latino population, and those patients who are lower income do not have the luxury or privilege necessarily to socially distance, or they may be essential workers that still need to go to their jobs and cannot socially distance because of their professions. And what we found is that the African American patients were testing positive at over 2 times the rate of other unique races. And they also tended to be more engaged with this remote patient monitoring platform as a result. We also wondered whether technology might be a barrier to access for vulnerable populations and low-income populations. However, we were finding that it's not, that the availability of smartphones and smartphone education is higher now than in the past. And we were finding that we were able to reach the right patients using this platform. And then we have some early data to suggest that patients who are digitally active are less likely to be hospitalized because they're taking care of their symptoms and getting the right communication from the clinical team. So that's something that we're continuing to study as well to see how we can quantify that. And the next slide will show a little bit more data about that. So where we're seeing the bigger impact is a reduction on inpatient admission within 30 days of the COVID-19 test. As you can see, if a patient is engaged on the Get Well Loop platform, there's a 1.5% admission compared to the non-RPM patient, which is 3.4%. So you can see that there is an impact there from our initial results from April to June 2020. We saw a much smaller impact on the visit to the ED within 30 days of a COVID-19 test, but that is something that we're tracking further. But we're seeing the bigger impact on the lower hospitalization rate. Next slide. So I'll talk now about our third and final initiative with the COVID pandemic, and then we can open it up for questions. Over the summer of this year, of 2020, as you can see, we've been very, very busy with our PPE Factory, with our Get Well Loop, remote patient monitoring. Innovation was approached by yet another challenge from our Vice President of Population Health Management, Dr. Susan Mani. She came to us with a unique challenge. She told us that her department was unable to reach 25 to 30% of high-risk Medicare lives at LifeBridge Health through telemedicine due to lack of digital access and high socioeconomic needs that were exacerbated by COVID-19. And her idea that she wanted us to brainstorm around was, can we launch mobile clinics that would bring nurses and social workers into the homes of our vulnerable populations and high-risk Medicare patients in West Baltimore, because they might not be able to access our drive-through testing sites due to lack of transportation. They might have addiction issues or behavioral health challenges, and they're not accessing the needs of the clinical needs and the health risk assessments that they need to get done. And we had never done this before. We had never had a mobile clinic program, and we rose to the challenge, and we really did a study of other health systems nationally. And this concept is not new. Mobile clinics have existed for many years in the United States, and they have found to result in higher patient engagement and reduction of hospitalization and readmissions into the emergency department. And we took on this challenge, and we spent the summer really planning, and we kicked off a 6-week pilot from starting in June of 2020. We started small with just 2 vehicles. As you can see in the picture, it's really a small shuttle bus from LifeBridge Health. Each shuttle bus had 1 nurse, 1 social worker, and 1 driver that took them to these patients' apartments. And we found, oh, the other thing I should mention is, to my point earlier, not only are these high-risk Medicare lives, many of them are of an African-American background. And as we know, within that community, there was a higher risk, and continues to be a higher risk, of COVID-19 morbidity and mortality. And we wanted to make sure that our healthcare services were reaching this patient population. We found a lot of interesting lessons through our initial mobile clinic pilot, which I'll show on the next slide. So over the 6 weeks starting from June 2020, we were able to see 316 patients. For all of the patients, a social assessment screening was done. And for all of them, we had to conduct virtual visits as well. So we provided an iPad to the teams. We initially thought only 50% of these patients would need a virtual visit, but we found out that almost 100% did, because they had multiple chronic conditions. Typically, those were hypertension or obesity or diabetes. And because of the complexity of having multiple chronic conditions, they needed a virtual visit with our PA in our virtual hospital, who could assess the patient and set them up for a follow-up with a primary care provider as well. We also did 288 COVID-19 tests using this mobile clinic platform. So we found some of our key insights were that a very high number, over 80%, had abnormal blood pressure. Almost half of the patients had over 3 chronic conditions. A third of the patients had not seen a PCP in the last 12 months, and 22% of patients needed immediate follow-up. One of the pivots that we had to do during this pilot was, we initially were seeing patients in their apartment, but there was a fear from the patients about COVID infection by having a nurse or a social worker coming inside their apartment space. So we were getting a lot of patients declining appointments and not wanting to see someone. About halfway through the pilot, we pivoted to what we call the neighborhood tent model, where we use the common spaces in the apartment buildings, typically on the ground floor with outdoor space, and we set up tents, and that led to a dramatically higher number of patients who wanted to take part. Because it was outdoors, I think, and also because they were able to see other patients in their apartment buildings in West Baltimore take part. So that reduced the fear, and they were able to see the benefits of participating in this program. So as a result of the impact that we found in the original 6 weeks, we are now launching phase 2, which will go live on January 5th, and it will be taking place over a longer period of time, over 6 months. And we are going to try to cover more zip codes, because we now have additional funding from our hospital, and we are adding new use cases. So in addition to COVID tests and health screenings for adult chronic patients, we're also adding pediatric immunizations. As you may know, a lot of families have been delaying their shots and vaccinations for their children because of COVID fear. And we're hopeful that by bringing these mobile clinics into the community, we will be able to increase the amount of pediatric vaccinations. And we have been very fortunate to get donor support for this use case as well. That's helping to support the program. What I really like about this mobile clinic initiative is that it's really a platform. You can use it for whatever is most necessary or helpful for our community of patients. So, when we hear about the COVID vaccination that just got FDA emergency approval today for the Pfizer vaccine, we're getting ready to roll that out for our providers later this month in December. But at some point over the next 2 to 3 months, we're going to have to think about how we offer COVID-19 vaccinations to our vulnerable populations as well. And this mobile clinic program may be a way for us to get the vaccinations out into the community. So there's a lot of potential. And the last point I'll make before we go into Q&A is one change that I've seen with the innovation department's focus over 2020 is that it's no longer just about mobile applications for the primarily healthy patient population or higher income population, or just about AI for physicians for clinical triage. The social determinants and community aspect has really taken on a major priority for innovation. You cannot have innovation anymore unless it's for the full community and you're reaching lower income, vulnerable populations, racial minorities, and these types of initiatives like our mobile clinic and remote patient monitoring are really helping us extend care to our full community, to the patients who need it most. And I see that as a major theme, even after the pandemic ends and even after a vaccine comes out, because some of these inequality issues and disparities that have emerged are not going away. They're not going to be solved in 6 months. So I do think innovation and technology will continue to play a role to improve healthcare. So with that, we can open it up for Q&A. Thank you.
And Marco, just to check, how do you want to run Q&A? I think I saw some questions.
Yeah, why don't we start with the ones that are in the chat bar. That might be the easiest. And if you all have questions, why don't you just type them in there? First, I just want to thank you guys. That was a great presentation and some really interesting points made around how to leverage those innovation resources in different ways, whether it's starting these new companies or addressing immediate issues within your organization. It's really really fascinating stuff, and the points you made about kind of the shifting focus of mobile technology and AI, which have been buzzwords in the industry the last couple of years, to really and I think rightfully so, focusing on social determinants of health and the need to address those and focus innovation around those things are just it's a very, very good point you made. And so I think that's pretty similar along the lines to what Brian was asking, but you may want to elaborate. He said, this comes from Brian Sims, who's also an officer here for HFMA. He says, what have you found that has been the linchpin to connect entrepreneurial endeavors with needs and interests of healthcare providers and payers? In other words, what value proposition seems to most pique the interest of those who make the decisions to invest?
Sure, and I can jump in and give Pothik a break since he's been presenting. I think the things that we see that work best when trying to connect new solutions, entrepreneurial solutions, with challenges that we might be trying to face are, well, here's a few points. One, first and foremost, there has to be some sort of connection to a clear value proposition that for CareFirst, our North Stars are we often point to our North Stars of affordability and access. I think affordability and access paired with the realities of cost savings, better management of cost of care are the kinds of things that we're often looking for. I think there's also projects that I've seen be successful as well, often tied to changes in policy or regulation that you can imagine an organization like CareFirst might, or just general large healthcare organization, is going to be slower to react to. So as an example, new regulations around our requirements to have really strong, or rather accurate, provider directories is something that's creating an impetus around providing or creating solutions, looking for partners for solutions that try to solve that challenge. I think another observation that I would make around where the connection is strongest is when there is a recognition of not just the role of the payer in that solution, and this is part of why programs like 1501 Health we think are going to be important, but the role of the other ecosystem players. As Pothik was mentioning, and to add on to it, we often see businesses who articulate a business model that represents one or the other of the key stakeholders in healthcare, but maybe doesn't recognize the role of both. And so partners who understand you as a payer play this role, and this is how we want to engage you, and this is how we're going to tie into the other elements of your ecosystem, bring a greater degree of maturity to the table that help us understand that those organizations can in fact solve our problems, and there's not going to be a gap elsewhere in where they're coming to the table. The last comment I'll make, and then certainly pass it to Pothik for his thoughts, is that, and I ran into this challenge and this fallacy a little bit when being in the entrepreneurial space myself, that it's almost harder for a large organization to do a really small pilot than to do a larger program. And I'm not saying startups should pitch massive programs to health insurance organizations, but recognizing that reality and trying to help the organization understand where you can prove or de-risk the value proposition in a way that removes some of the significant administrative efforts that do exist when an organization as big as both of our organizations try to engage in a pilot program of some sort. But I think LifeBridge has probably cracked the nut on that a little bit better than we have so far. But Pothik, over to you for your thoughts.
I think aligning the startup's value proposition with the strategic priorities of the health system and the environment that we're in is really key. So for the entrepreneur to understand what are the financial pressures that the health system is facing, especially with COVID, with ambulatory volumes being down, with surgery volumes being down, really making the connection between your technology and the return on investment is more compelling than ever before. Being patient and understanding that there are still some bureaucratic elements that you may need to go through, and our innovation department can certainly help with that. But that persistence and resilience is really helpful. I see that one of the attendees here, Jeff Mund, is from LiveChair, which is one of our pilots that we are partners that we're working with. LiveChair is a great example, and they were recognized by the state of Maryland as one of the top 20 promising startups right now as well. LiveChair is a great example of a company that's been really willing to work with our innovation and population health department and our Grace Medical leadership in West Baltimore to implement a program that makes sense both for the startup, but also for LifeBridge in terms of our population health management strategy. And it takes a lot of time and meetings, but having that openness and communication really helps.
Looking at the next question here. Are we planning to, I think this is probably for both of Pothik, are we publishing any of our successes? In particular, the question is pointing towards the importance and the necessity of having this sort of SDOH data in order to show impact and support. For the programs that we're doing, there will be some more public information about the results. Those will be coming more through our partner, Socially Determined, as opposed to being published by CareFirst. But I know the intention is to try to take those learnings and definitely socialize them. Curious, Pothik, what LifeBridge's plans are there?
Yeah, the answer is yes. We are publishing our mobile clinic data and outcomes with Johns Hopkins University Press, and it will be coming out in January. So keep an eye out for that. And then the next question around utilizing volunteers to help, especially your retired staff, the answer is also yes. We had our PPE Factory running 7 days a week, and the only way we could do that over the weekend was with community volunteers, especially those who had sewing experience. And that's the only way we were able to reach our initial quotas that we needed for production. So they were a huge help. And we also worked with retired physicians who who came out of retirement for our remote patient monitoring for Get Well Loop. They were able to not only answer patient questions on the online platform, but also train our younger residents who are volunteering as well. So really everyone came out, and it was really incredible to see.
I know we're pretty much at time here, but I think that actually answered also the second question there about retirees helping out with the different programs. And it sounds like both of you guys have certainly done so there.
Any other questions from the audience? And any parting words you want to leave with these finance professionals who often hold the coin purse and the value proposition to invest in these companies? I think one of the biggest challenges is, and we'll talk a little bit later in the later session, is the reality of the pressure on our margins and the fighting of or the competition for strategic capital dollars.
Mm-hmm.
This obviously, you make investments here, it's pulling away from buying a new MRI machine or potentially investing in physical space or spending money on human capital. So any pitches here that you would like to share or other words of wisdom here?
Sure, I can. Oh, I was just going to say, maybe a couple of parting thoughts. One, if you are working with companies or yourselves are early stage ventures, certainly apply and reach out for more information on the 1501 Health program. I think we're also looking for that community development. And so if there are folks in this group that want to bring sort of their financial background and skill sets to helping companies, I think we're certainly interested in learning more about how you might plug in and support the growing ecosystem we're trying to foster here in the community. And then maybe on the last point, I think the more that organizations like LifeBridge, like CareFirst recognize the impact and the involvement they could have in sort of the investment in the financial market, I guess I'm sort of describing it through the investment activities, we are looking for those kinds of co-investment partners who bring different levels of subject matter expertise to the table. We have the healthcare background, but we do often co-invest with other partners who bring either the finance or their subject matter expertise to the table to help us be confident that we're going in the right direction. So relationships with, I guess, quote unquote, strategic investors like us, certainly a way to sort of share the de-risking of potential investments.
Yeah, just to add to that, it is a real challenge to decide between immediate asset needs that the health system needs to invest in to provide the patient care and stay competitive versus these higher risk future strategic opportunities that may or may not pan out. And that's a real challenge. And I would say for your HFMA members that take a look at the portfolio that we're building through 1501 Health, because these new startups do go through vetting and some de-risking, as Mike mentioned, and try to combine your immediate financial needs and risks with a longer term view about where the disruption may come from. And you want to stay ahead of the disruption and not get disrupted negatively. So that's my parting word.
Thank you both. A great presentation. For those who want to listen to it again or make their colleagues aware, we will be, it was recorded, and I believe we'll be posting it to the website for others who weren't able to join. I know everyone's very busy with COVID right now. And so those who have time, also, we have the afternoon session beginning at 12:30. We got a great panel, a really interesting group of people. Hopefully people can join for that as well. And then here, just a recognition of our sponsors. They've always been very supportive of us and the efforts that we provide to provide education to the healthcare finance professionals here in the state of Maryland and across the country, and couldn't do it without these very important sponsorships to support our mission. So appreciate everything, and hopefully you all can join us for the 2:30 session. Thank you.
Thank you all.